Thank you so much for the opportunity to invite you to become a part of the V-Registry investigators group with the dedicated studies that are already ongoing. This is a part of a path we started back in 2019, following the winter meeting of 2019, looking at the similarities and the controversies of the different guidelines around the world, with a dedicated publication of more than 60 pages you can find in PubMed. In that publication, we were looking indeed at the discrepancy that you can find in the different recommendations around the world, which is a bit strange considering we start all from the same literature, and we don't usually have an analysis of appropriateness and sustainability for each and every country, for which we should agree more on how we look at the scientific evidence. You have a typical example of this in what happened in 2022 and 23, basically the same year. American side of the Atlantic, indicating that thermal tumescent is equivalent to non-thermal non-tumescent, while if you fly on the other side of the Atlantic, one of the European documents stating that a thermal tumescent is still superior to non-thermal non-tumescent. How is it possible considering that the literature is the same and there was no analysis of appropriateness and sustainability for the different countries? The further step we took in this project was looking at what is evidence-based compared to what is fake news in vein and lymphatic medicine, starting from a publication showcasing more than 40% of medical websites, including fakes, shared 450,000 times in a time of 5 years as a period. We did this publishing 100 pages in International Angiology Journal in 2023. I deeply thank Professor Fakhri and all the Egyptian friends and colleagues and friends from all around the world who took part in this global effort that was also translated in layman terms for our patients. So you can find it in the Wing Foundation website. Now, the current step forward is done with the gentleman you see in the front. That is Professor Gordon Guyatt, the guy who invented evidence-based medicine as we know it today, the founder of the GREAT group. You all know the GREAT system 1A, 1B, 1C. And with him, we will develop the initiative in Rome this September, together with institutions in many different countries, globalizing the evidence while nationalizing the recommendation. What does it mean? That we put on the table the meta-analysis and the data that you can find in the literature. We review that together, as we've already done with the first document, and then your national working group are deciding what is appropriate and sustainable in each and every single country. Of course, what is, for example, appropriate and sustainable in Italy might be different from Canada. This is the valid institutional program, which is a venous and lymphatic international document. You will find in Rome many of these tables that are basically meta-analysis that are looking also at the quality of the evidence of that meta-analysis, because just having the meta-analysis is not enough. To give you an example of the 7 meta-analyses we found regarding the superficial venous treatments, one was discarded because unreliable in terms of quality of the evidence. This is something we must do because starting from 2018 with FDA and then also European Medical Association and NICE demanded that we combine the evidence-based data together also with the real-world data. And that's the other part of the project related to V-Registry. If you really think about that, we don't have a randomized comparative trial with the use compared with the no use of parachute to save life when you're jumping out of the plane. This is a real paper you can find in PubMed that is discussing how we cannot rely just on randomized comparative trials. Sure, they are important, but we need to bridge the traditional trials with the real-world data. And the V-Registry is exactly this. This is a project that started looking at papers like the initiative that is called the RCT Duplicate, where basically they looked at the 32 different randomized comparative trials, and then they reproduced the results in a real-world scenario, showing that up to 3 cases out of 7 are not overlapping in the forest plot the result of the randomized comparative trial. So you say again, if I take the same basically design of the randomized comparative trial, but done in a real world study, I will change the final result in 3 cases out of 7. This is because we have an internal validity that is the one of the study population, so the characteristics that we select on purpose for the study, compared to what is happening for real in the outside world, outside that study population. And this is particularly evident in varicose veins. If we think about that, it's the San Diego study that already showed us even the ethnicity impact on chronic venous disease manifestations. It's about lifestyle. Think about somebody going to the pool with 80 millimeter mercury of water acting on the legs compared to somebody who is just sedentary. If we don't report these things, clearly we have major compounding factors. Registries are a fundamental tool, but doing a registry is not difficult, but at the same time, doing a proper registry is extremely difficult. What I mean by that is that, of course, registries are already out there, but there are like some serious limitations that are requiring our attention to move forward. First of all, as in medicine and data protection, so we have to use tools that are extremely solid in terms of privacy, and that's why the registry is a global project that is unique in its having a dedicated legal study that is working just for ensuring compliance to the privacy. Then the main one that is the time. We don't have the time to write everything or to jot down everything during a visit. So thanks always to the legal team, we were able to find a way to legally connect with the patients even before the patients comes to us, so that the patients before coming to the visit can already put all the information that are needed even before meeting the doctor. The global nature of the registry, for which we included the 13 different languages, including Arabic. So I suggest you, if you like, to go to beregistry.com and become part of this, following the language you prefer. In this way, you will be able to participate to studies that are already ongoing, like the Veritas one, being Vatican's real-world data investigation on treatments and standards, which is a study that is looking at the burden of the disease in the different parts of the world. So in conclusion, ViewRegistry is unique in the fact that it allows you to connect with the patients even before the patient comes to you. It is fast and standardized. We all use the same backbone of data. It is customizable, meaning that if you want to do an extra search, you can do whatever you want in terms of research, as long as moral, of course. It is open to all healthcare professionals in many different languages all around the world, and it is already compliant to all the international privacy laws and IRB approved. So I hope you will visit the page and become part of this group effort that is also fueling artificial intelligence, as per this paper we published back in the days, because indeed all these anonymous information that we are putting in, of course, are contributing to the machine learning of the artificial intelligence. This started in Indonesia, for which, once again, I deeply thank Professor Fakhri and the Egyptian Venous Forum engagement in this global project. Ayman has been with us since the very first days all around the world. The benefits of the ones who are taking part in this project is a free registration for world events and possibility to be faculty on the events presenting their own data, and they can also extract the aggregated data of their registry. So it's always the pleasure of with whom we are traveling around. So unfortunately, I could not be with you in person this time, but I really look forward for traveling toward Rome and then also to Buenos Aires with Professor Fakhri and all the Egyptian friends. We'd like to join us in September 36, again in Rome, and in October 8 to 11 in Buenos Aires. I remain at your disposal, and I deeply thank you for your time and effort. I'm sorry not to be there, but I'm flying today. So reach out to me, to my contacts whenever you want. Thank you.
Thank you, Sergio. I have to announce two things. First, lunch is ready. الحاجة المهمة جدا اللي عايز أقولها لكم، إحنا النهاردة إن شاء الله نحتفل بإقامة المسابقة التي تحمل اسم المرحوم الأستاذ الدكتور طارق رضوان، أحسن بوستر في مجال علاج الجروح. أستأذنكم في قراءة الفاتحة للدكتور طارق. Thank you. Now I would like to leave the mic to my dear friend, Professor Islam Barsim from the university, is going to tell you and announce the judges for the fellows and tell you when the music will start.
Thank you, Dr. Ayman Fakhri, for this kind invitations. During lunch, we will invite you all to share us with our fellows, sharing in Dr. Tariq Radwan competition for wounded management. We will invite our professor, Dr. Sergio Mate, Dr. Saeed Al-Mallah, Dr. Ayman Ziyada, Dr. Roy, or Dr. Samih Zara, Dr. Tariq Abdelaziz, Dr. Mitwalli Ragad for our board, and our competitors will be ready for starting now. Okay, we will start. Thank you.
Thank you very much. This will conclude the session, and it's lunchtime now.
Dr.
He also had the critical limb ischemia. Imaging shows 8 cm occlusion in superficial femoral artery and 50% popliteal stenosis and the tibial vascular disease. She presented with us with wound foot dimension 5 by 6 centimeter infected. This patient, the angioplasty is not a safe option for her. So we took a conservative and aggressive wound care approach. The first step was surgical debridement for the wound to remove the necrotic tissue. Then we introduction a very specialized topical treatment called Granulux. Granulux contains trypsin, which helps clean the wound, plasma beer to boost the blood flow and healing, and castor oil to keep the wound moisturized. Importantly, Granulux also used as HyperOx, which enhance hemoglobin concentration over the wound, essentially improving oxygenation in the tissue. As you can see in the final image on the poster, the wound healed completely over the course of 11 weeks. This case highlights the powerful impact of optimized wound care and oxygen therapy in patients who are not candidates for the vascular surgery. In summary, this case demonstrates that with timely intervention and effective wound management plan, we can achieve healing and avoid severe outcomes like amputation, even in high-risk patients. In the end, I have no disclosure. Thank you for your attention.
Thank you, Ziad. This is our commissioner, Dr. Said.
هو انا عايز اعمل كومنت في الحقيقه على اولا الصور اللي هو حاططها دي. الصوره الاخرانيه دي الاضاءه مش نفس يعني لما اشوف انا الصوره دي انا هحكم عليها بالاسكيميا الاسكيميك ليم سيفيرلي اسكيميك ليم. الصوره الاخرانيه دي مهمه طبعا. انت يعني حاطط الصور ما انتش مش مرتبهم. خد بالك دي نمره واحد. كويس. ايوه ما هو انت بقى شفت انت خدت بالك انت يعني مشيت اه ماشي اوكي. الصوره الاخيره دي ما هياش ما بتوحيش. مش نفس الاضاءه مش نفس السيتويشن. كان المفروض يبقى نفس المكان. انما انت الحاله نو لا مش نو ريكارنت. انت عملت لها فولو اب لمده قد ايه؟ 6 شهور بعد وكل الارتيريال ديسيز اللي كان موجود ده راح. اوكي ما ينفعش. اوكي شكرا.
Thank you, Ziad. دكتور طارق عبد العظيم.
So at the beginning, I would like to mention that it's a great honor to be presenting in front of such massive surgical expertise. I'm Dr. Omar Nadi. I'm Dr. Omar Nadi. I'm here today to present a case for you. It's quite challenging, as you will know now. At the beginning, our patient is 65 years old with chronic peripheral arterial disease with a cliche history of hypertension and diabetes. He came, you might come closer to the screen. He came with complaining from this necrotic wound at the upper left photo. It's on the sole of the right foot. Of course, we made initial assessment. We found pulseless limb. We went for duplex followed by CT angio. We found there is massive stenosis in the popliteal artery together with the tibial vessels. So decision was taken for this patient to be going for angioplasty. What was done for this patient? First, we went for popliteal superior ascent together with ballooning of the tibial vessels. This was for the surgical part. And this was followed by transmit amputation, as you can see in the second photo. We went for the angioplasty and transmit amputation in the second photo, as you can see, followed by aggressive debridement and sutures approximation. We use sutures to approximate the wound, not closure, of course, to avoid risk of recurrence of infection and necrosis again. And after this surgical manipulation, we went classically for the VAC in these kind of situations. Of course, good coverage of broad spectrum antibiotics, which was directed by the culture and sensitivity. And after 90% closure of the wound, we went for finally with dressing by silver nitrate. So this case is all about two things to achieve the balance between a good surgical decision, good surgical manipulation, followed by post-operative decent wound management. Of course, another thing to add, we didn't leave the patient without anticoagulation protection. We gave him a voyage regimen. We give him rivaroxaban together with aspirin for 6 months to prevent, of course, as a protective maneuver for this patient. And it was life-changing. This patient was destined to go for below-knee amputation. This was quite life-changing for him. And this completes my presentation. And Mazik is yours back again, sir.
Thank you, Omar. With Dr. Tariq Abdelazim.
Very nice and challenging cases. Two comments. First of all, you did not put the title of the presentation, which is important. So if somebody walks in, he needs to know what we're talking about. So the title is missing. The second thing is very important in chronic ischemia or peripheral vascular disease patients is to see the angiogram. You did not put the angiogram, which is very important in order to decide which mode of revascularization you use. I mean, you chose to go for endovascular intervention with a superior stent in the popliteal artery. Somebody else may have prepared a different form of revascularization based on the angiogram. So I think with these cases, the angiogram is a very important slide to be put on. Yes, that's a very, very nice and challenging case.
Thank you, Dr. Tariq. Then for the third one.
يا جماعه من فضلكم الاي تي هيبقى معانا في عند الكمبيوتر من فضلكم الاي تي.
Hello, doctors. Dr. Isra Idris, and I'm going to talk about how to save a patient's leg from below-knee amputation using advanced wound care. Our patient is a 48-year-old diplomat who unfortunately stepped on broken glass, which caused extensive infection and collection in the heel. He sought medical advice before visiting us, and his doctors put a drain through his sole with foot. After that, infection spread, and they decided to go for below-knee amputation. That's when he sought our medical advice. The patient, they were excited and macerated. The biggest ulcer was in the heel foot. It had dimensions of 9 × 5 × 1 centimeter. He was, however, generally only showing signs of infection and localized acute infection. However, he had intact circulation and pulsations in using a duplex, arterial duplex, and by clinical examination. The patient underwent surgical treatment and B2 mission and tissue biopsy statistics according to the culture results. For 4 weeks after that, we used a negative pressure vacuum device to enhance healing, and then for 8 weeks, we used silver foam dressing until complete healing of all wounds in the sole of foot and at the amputation site. So the outcome was complete healing of all wounds and saving the patient's leg and career. Thank you.
Thank you, Isra. And our professor, please.
Yeah, I'm looking to your presentation, all this is the presentation of the right. This is the food, Okay, what you have done in this case is done debridement for the heel only. Then after that, you put the patient in the back. Okay. So you should have an X-ray for the foot to be sure that there is no osteoporosis in the bone. It's very important before you go that. You did mention X-ray. But we should put it in there. And the duplex study is okay. The impact of station is okay. So it's fine. Okay.
Thank you. Isra, your then the fourth one with Dr. Sergio.
Good afternoon. First of all, it's my pleasure to be among you, my great professors and my esteemed colleagues. So thank you for giving me this opportunity. I am Rahim Abdurrahman, and I'm going to talk about a really interesting case about a 58-year-old gentleman presented to us with a wet gangrene in his left big toe. My patient was uncontrolled. My patient had uncontrolled diabetes and hypertension, and he presented to us with a really poor general condition. The lower limb focused examination and the imaging revealed an 80% occlusion of the popliteal artery, the left popliteal artery. So our management plan was it depended on 3 main domains. First, to improve the general condition of the patient. Second, to revascularize the lower limb. And after that, debridement the necrotic tissue. So after proper supportive management and the treatment, our patient gone to a left popliteal artery ballooning angioplasty with a superior stent, and it took place successfully. After that, the patient undergone amputation for his big toe and good surgical debridement. And under coverage of good antimicrobial agents, a negative pressure vacuum was applied for 3 weeks. After that, a daily dressing with a tetrasol spray was done for other 8 weeks. So the outcome was an impressive improvement in the patient's general condition. The patient become more compliant to his anti-diabetic and anti-hypertension treatment, and the whole about 11 weeks. So the take-home message was the importance of the general examination, and it took the patient as a whole, not only the injured limb, and also the importance of the multidisciplinary team. As the patient presented with signs of septicemia and poor general condition, we started to involve a multidisciplinary team of medics and ICU team to see or put a complete management plan. That's it. Thank you.
Thank you, Rahim, for this poster. Then our opinion of my professor, Dr. Saad.
Thank you. It was a wonderful presentation. Until now is the best in my opinion. No offense for the others. What I would recommend, being the poster, the images are very important. You have very nice images in here. I would recommend to enlarge them because you have a lot of space in here, in here, in here, which is not used. But overall, the examination was very clear in your presentation, and I really like that you underscored the importance of the multidisciplinary team in such cases, because also we deal a lot with such cases, and I know how important it is to work in a multidisciplinary team. So congratulations, it was a very good presentation.
Thank you, Sergio. Thank you, Rahim. This your certificate. Thank you. No, 10, yes, 10 to 10. All 10 competitor. With Dr. Ayman Ziada. Dr. Ayman. Dr. Muhammad Mahmoud Farad. Yes.
Good evening, everyone, my dear colleagues and professors. This is Dr. Muhammad Farag, an intern doctor at the Alexander Amin University Hospital. Today, I'm going to present an interesting case about an important topic, which is the cellulitis. Cellulitis affects about 14 million cases in the United States every year. So this is a quite common disease. So let's start with our case. Our case is to a 62 years old male patient that is first presented by a unilateral left lower leg swelling, pain, and worm. And by history, he denies either the history of trauma or an insect bite. But he recalls a minor scratch that has happened a week ago. His past medical history has nothing except that he is a type 2 diabetic patient. On medical examination, the patient was found to be unstable. And by the wound itself examination, on inspection and on palpation, there was a skin breaks, abrasion, discoloration, and even a purulent discharge that was noted. Regarding the management plan, so after the initial resuscitation steps that was have done, an aggressive parenteral antibiotics were prescribed. And in 2 weeks' time, the patient develops a white crustaceans and spreading infection. So the surgical deployment decision was made. An intraoperative alginate calcium sodium dressing is used here. This was the results in just 4 days afterwards, the silver infused dressing that used, because the patient here has يعني almost completely healed, except for a few areas. That some areas here that he haven't resolved it yet or haven't healed yet. So and silver infused dressing was used here on the regular surgical dressings, and that was the final visits in just 2 weeks after the surgical department. The outcome here that the patient has no longer has symptoms, and he regained his daily life activities in just 2 weeks after the surgical department. That's it all, and thank you.
Thank you. Thank you, Muhammad, for this great poster. Yeah.
Is it common to do debridement in cellulitis? It is not common, yes. Because the danger you can deepen if you are not very careful. Yes, this is serious, okay?
Thank you, sir. And then our opinion of our dear Dr. Ayman.
I want to check, why did you choose this kind of dressing specifically? Why you choose alginate calcium first and then silver?
Here I started with alginate because the wound here is expected to be in a highly exudative. So this alginate will create a gel, and also having it on calcium that promotes the coagulation cascades into the coagulation and the hemostasis. So that will help the patient at first. Then I use for this, because there's some few areas that haven't healed yet, I use the silver because it is the best antiseptic that can be used here. So I dress it. That's all. Thank you, doctor.
Thank you, Mohammed, and this certificate. And the 6-1 was Dr. Yusuf.
Good afternoon, everyone. Today I'll be presenting this case report. My name is Yusuf Abul Khair. The title is Wound Management of a Venous Ulcer. Venous ulcer are a type of chronic wound caused by venous insufficiency, where impaired blood flow leads to buildup of pressure in the lower extremities, usually leading to skin breakdown and persistent ulcers located around the medial malleolus, or what's called the Gator's area. This patient presents medical history, no comorbidities, no diabetes, hypertension, ischemic heart disease, complaining of numbness and tingling sensation in his peripheries, venous ulcer, and pain. On examining the patient with Doppler, we discovered an SFA lesion with 80% stenosis, tibial vessels disease affecting posterior tibial artery, anterior tibial artery, and peroneal artery. Patient was then diagnosed based on these findings with peripheral neuropathy, venous ulcer, and critical threatening limb ischemia. On examining the ulcer, as we can see, he had 2 ulcerations, the larger one measuring 5 centimeters in width and was oval in shape, and the smaller one measuring 1 centimeter in width while being circular in shape. The edge was irregular and elevated, with the base showing healthy red granulation tissue with no slough or necrosis, and the surrounding skin showed hyperpigmentation and thickening. Isn't this the hyperpigmentation? Okay, and why is A? To us like this. This is the presentation? No, it's not common, no. It's usually one larger ulcer. No, we only performed Doppler in the patient, and then we proceeded with the management.